Hello, and thanks for the opportunity to discuss cryoablation for breast cancer, experience from the pandemic. I'm Dennis Holmes. I'm a breast cancer surgeon and cancer researcher, and also serve as medical director of the breast cancer program at Adventist Health Glendale Medical Center in Los Angeles. There's no question that the COVID pandemic has been an unprecedented time for the breast cancer community. COVID-19 has placed tremendous burden on healthcare personnel, equipment, supplies, and services, which led national organizations to recommend delaying breast cancer screening and forced hospitals to postpone elective surgical procedures, even cancer procedures, with the goal of preserving limited healthcare resources. The end result of these delays is an increased risk of cancer progression, which is expected to result in 5,000 extra breast cancer deaths by the year 2000 in the US alone. In an effort to minimize the risk of cancer progression, multiple organizations developed and published elaborate pragmatic recommendations for prioritizing and triaging patients for treatment. Let's start over. Hello, and thanks for the opportunity to discuss cryoablation for breast cancer, experience from the pandemic. I'm Dennis Holmes. I'm a breast cancer surgeon and cancer researcher, and also serve as medical director of the breast cancer program at Adventist Health Glendale Medical Center in Los Angeles. There's no question the COVID pandemic has been an unprecedented time for the breast cancer community. COVID-19 has placed tremendous burden on healthcare personnel, equipment, supplies, and services, which led national organizations to recommend delaying breast cancer screening and forced hospitals to postpone elective surgical procedures, even cancer procedures, with the goal of preserving limited healthcare resources. The end result of these delays is an increased risk of cancer progression, which is expected to result in 5,000 extra breast cancer deaths by the year 2030 in the US alone. In an effort to minimize the risk of cancer progression, multiple organizations developed and published elaborate pragmatic recommendations for prioritizing and triaging patients for treatment. Here's one such publication from 2020, developed by a consortium of 5 national organizations in the US. However, completely missing from their discussion about the pragmatic management of breast cancer was the option of cryoablation or tumor freezing. That prompted me to publish in the same journal article, in the same medical journal, this article on breast cancer care during a pandemic, an opportune time for cryoablation. So what is cryoablation? Cryoablation is defined as a medical procedure in which extremely cold temperatures are used to destroy tissues. The word is derived from the Greek word kruos, meaning icy cold, chill or frost, and from the Latin term ablatum, to remove. Modern cryoablation systems utilize liquid nitrogen as a cryogen, as well as a partially insulated needle-like device called a cryoprobe, through which liquid nitrogen circulates. The transition of liquid nitrogen, which has a temperature of -185 Celsius, to gas nitrogen causes freezing of the surrounding temperatures via the Joule-Thomson effect, which extracts heat from the surrounding tissues. Most cryoablation protocols call for a 2-freeze method, where each freeze spans approximately 6 to 8 minutes, separated by a 10-minute thaw period. Tissue destruction is achieved through 5 key mechanisms: osmotic injury leading to cell lysis, mechanical injury by ice crystals, which damages cellular structures, vascular injury from thrombosis of tumor-associated blood vessels, apoptosis or programmed cell death, and immunogenic injury from immune response to the release of danger signals from damaged tissues. With cryoablation, we aim to achieve the same goal that we seek with lumpectomy, which is to ablate the cancer, shown here in red, as well as a 5 to 10 millimeter gross surgical margin, shown here in gray. This typically creates a 4 by 3 by 3 centimeter zone of necrosis, again shown in gray, which requires the creation of a 5 by 4 centimeter oval shaped ice ball, shown here in blue. So in order to achieve a 4 by 3 by 3 area of ablation, we must freeze a larger volume of 5 by 4 by 4 centimeters, generally speaking. And again, that is done with the effort of freezing a surgical margin around the tumor spanning a minimum of 5 millimeters. The image also shows the cryoprobe in black, as well as the green uninsulated segment of the cryoprobe, which is the actual portion where the freezing takes place. Also, like lumpectomy, cryoablation may be followed by adjuvant systemic therapy, such as chemotherapy, endocrine therapy, and or radiotherapy. To understand the efficacy or effectiveness of cryoablation, we can look to 3 ongoing single-arm clinical trials evaluating cryoablation followed by adjuvant systemic and radiotherapy for stage 1 breast cancer. 2 of these are US-based studies, 1 is from Japan. What we see are very low local recurrence rates, less than 3%, at 3 to 6 years of follow-up, which is comparable to what we see with breast-conserving surgery. Now, as with standard breast surgery, patient selection matters. So I want to stress the importance of a proper pre-treatment workup, including mammography, breast ultrasound, lymph node ultrasound, and ideally breast MRI for the best determination of extent of disease. Multidisciplinary management is also important, with consideration of systemic therapy guided by tumor genomics. Adjuvant radiotherapy is also an important consideration. And of course, patient-informed consent is essential. In the pandemic publication, I outlined 6 pragmatic indications for cryoablation, where cryoablation may be used as either definitive therapy, completely replacing surgery, or as a stopgap or temporary measure to prevent tumor growth while awaiting definitive surgery. The pragmatic indications include stage 0 breast cancer, stage 1 breast cancer, stage 2 node positive or node negative breast cancer, stage 3 node positive or node negative breast cancer, stage 4 breast cancer, and locally recurrent breast cancer. Cryoablation can also serve as definitive or stopgap measures for patients that simply refuse breast cancer surgery. I'll discuss each of these pragmatic scenarios in the next few slides, beginning with ductal carcinoma in situ. DCIS has been excluded from cryoablation trials primarily because DCIS is generally not ultrasound visible, and existing cryoablation technology is optimally designed for ultrasound visible procedures. So there was an apparent conflict between the two. However, if we insert an ultrasound visible marker at the site of the microcalcifications, a marker like this tubular ultrasound visible marker on the image to the right, then the opportunity for cryoablation of DCIS greatly improves. Of course, the approach to treating DCIS with cryoablation is part of an overall trend towards non-operative and less aggressive management of DCIS. To further understand the role of cryoablation in the management of DCIS, I am currently conducting a DCIS cryoablation clinical trial, which is enrolling patients with lesions 2 centimeters or smaller as measured by imaging. Each participant with an ultrasound visible finding can undergo cryoablation under ultrasound guidance without placement of a marker. However, for those without an ultrasound visible component, they will undergo placement of an ultrasound visible marker at the site of the microcalcifications or at the site of the area of enhancement, and then undergo ultrasound guided cryoablation targeting the ultrasound visible marker. At 6 months post-cryoablation, all patients undergo core biopsy of the cryoablation site to document complete necrosis of the DCIS, followed by annual mammography. Although it is expected that DCIS will completely ablate the malignancy, which is what we found so far, the patients must understand that the microcalcifications will persist at the treatment site as the DCIS-associated microcalcifications are not dissolved by the cryoablation procedure. Of course, we've already seen some of the data regarding stage 1 breast cancer. Here's an example of such a case with the lesion shown here in the image to the left with the measurements. In the center image, there's a longitudinal view of the cryoprobe extending through the lesion. And on the image to the right, the lesion in a cross view or orthogonal view showing the cryoprobe at the center of the tumor as indicated by the arrow. Here's a photo of one such patient 3 years after cryoablation. She underwent cryoablation of a tumor in the upper outer quadrant of the right breast, measuring 1.5 centimeters. The center image shows a pre-cryoablation mammogram with an arrow pointing to the tumor in the upper outer breast. And then the third image shows a post-treatment mammogram 3 years after cryoablation, showing complete ablation and complete resolution of the mass, as shown by the absence of a mass adjacent to the arrow in the upper outer right breast. Here's the same patient, this is the same patient's breast MRI, pre-cryoablation on the left with an arrow pointing to the enhancing tumor, and 3 years post-cryoablation on the right, showing no residual enhancement at the cancer site. Although there are several ongoing single-arm studies evaluating the efficacy and safety of cryoablation for stage 1 breast cancer, the most important data will come from a randomized controlled trial that is currently under development that I helped to develop. In this randomized controlled trial, comparing lumpectomy versus cryoablation for women with stage 1 breast cancer, nearly all women will undergo a sentinel biopsy, adjuvant systemic therapy, and adjuvant radiotherapy consistent with the standard of care. The study is scheduled to open by the end of 2022 or early 2023. For patients with larger tumors, it might not be possible to ablate the tumor with a single cryoablation zone. However, to address this problem, we can combine and overlap more than one ablation zone with the cryoprobes placed 1.5 centimeters apart to eliminate skip areas between adjacent ice balls. Here's one such patient who presented with a multifocal tumor involving the upper outer quadrant of the left breast. She was advised to undergo mastectomy, but refused. In fact, she had a 3 centimeter dominant mass adjacent to the skin in the upper outer breast as shown by the MRI images. In addition to that, she had 5 less than 1 centimeter lesions in different parts of the upper outer quadrant of the left breast. Ultimately, we agreed to manage this patient by performing 4 separate overlapping cryoablations as shown by these red ovals, followed by excision of the skin overlying the tumor, followed by sentinel biopsy, along with sentinel biopsy, whole breast radiotherapy, and tamoxifen. 6 months after cryoablation, the core biopsy of the site was performed, showing no evidence of residual malignancy. Here's a photograph of the patient nearly 30 months after the cryoablation procedure with an essentially normal appearing left breast. And the breast MRI performed earlier this year showed no MRI evidence of malignancy. Sometimes we encounter patients with larger tumors that refuse standard therapy, such as lumpectomy, mastectomy, or adjuvant chemotherapy, neoadjuvant chemotherapy. Here's one such patient who presented with a tumor exceeding 5 centimeters for whom neoadjuvant chemotherapy or mastectomy had been recommended, but refused. I agreed to treat her breast cancer with cryoablation, which required 4 separate ablations in 2 separate planes for a total of 8 total ablations. We've also utilized cryoablation in selected cases to ablate grossly positive axillary lymph nodes, as shown here on the image to the left. The image to the right shows a longitudinal view of the cryoprobe extending through the grossly abnormal node. Lymph node cryoablation is primarily utilized in selected patients that refuse surgery and is safest and most useful when those lymph nodes are single in number and located in the lower portion of the axilla. Of course, these patients would be expected to undergo regional nodal radiotherapy to address microscopic disease in residual nodes, which is consistent with the growing trend to limit the extent of axillary surgery while expanding the use of axillary radiotherapy to reduce the morbidity of axillary surgery. Stage 4 breast cancer is another scenario where cryoablation has a role. While the debate continues regarding the benefits and risks of breast surgery in the setting of stage 4 breast cancer, cryoablation can provide a low-risk alternative to surgery for managing the primary lesion, to preventing local progression, and eliminate the source of future distant metastasis, while also avoiding the immunosuppressive effect of general anesthesia. And of course, these patients would be expected to receive systemic therapy along with cryoablation. The last pragmatic application that I'll discuss today is recurrent breast cancer, for which cryoablation may be used as an alternative to lumpectomy or mastectomy with little or no cosmetic effect on the breast. However, one should be aware that, particularly in the setting of prior radiotherapy, there's a greater risk of clinically significant fat necrosis when cryoablation is used to treat breast cancer after previous lumpectomy or breast radiotherapy. However, even a repeat lumpectomy will be associated with an increased risk of fat necrosis in those patients. So there's really no difference between that, I think, and the effect that cryoablation can cause or can produce. Regardless of the indication, cryoablation is a convenient alternative to surgery that may be performed in the office setting under local anesthetic, in most cases in less than 1 hour. In this regard, cryoablation can provide a way of managing breast cancer with minimal impact on healthcare resources. Patients are also able to drive themselves to and from the procedure, and patients are able to resume non-strenuous activity the day after the procedure. Pain and side effects are controlled with acetaminophen and a sports bra, causing minimal impact on quality of life. Although I may see many possibilities for cryoablation, it is also clear that cryoablation is not the best solution for many patients. But then again, nothing is the right solution for every breast cancer patient. However, cryoablation does provide a strategy for individualizing treatment, particularly for women seeking to avoid surgery or seeking to delay surgery, while also providing a pragmatic approach for managing breast cancer during a pandemic when healthcare resources may be limited. Thank you.